Hey, just answering some questions. So this question's about hammy strength and asymmetry. So I'm not sure how you're kind of saying or why you think the hamstring's strong. I suppose that's probably something I'd need to know. But I think for asymmetries, if it just depends again what test you're using. There may still be a little bit of an asymmetry, but ideally I wouldn't like it too high if you've done your job in the rehab process. So we in the mentorship, we just follow a step-by-step approach so that we don't go too fast too quickly, that ultimately you earn the right to progress. Because what I see a lot of times with athletes is that people avoid loading certain parts of the tissue. So that's where in the mentorship and the return to play courses we tweak the angle a little bit to give their brain no choice but to tolerate load. So if you're telling me that person can do Nordics, or that they can do, RDLs, they can squat real well, but then when you do your actual tests to, maybe in a more isolated fashion, but they're still not producing, torque, rate of force development, whatever variables you're looking at, that would make me very, very suspicious that the motor adaptations are at play here, and that you're still not happy to tolerate load in certain directions. So as I said, in the mentorship, we'd assess that, we'd find the directions. Ideally, I'd find that on the bed, and then from there we'd progress it on through a step-by-step process. So we'd make sure that we put you in a direction to get you tolerating the load on the bed, and then we'd build up graded exposure from that program or from that direction based on that. So that's a really good question that you can still be very, very well. So again, a classic example is a deadlift, where you might tolerate load well through the lateral hip, yet you get that weight up. You might see a knee valgus where you're using a lot of adductor magnus to hip extend maybe instead of lateral hip rotator. So really good question today. That again highlights, if anything, the importance of having an ability to tolerate load through a step-by-step graded exposure. So if there is asymmetries at 9 months, I'd be very, very skeptical that you're tolerating load in certain directions with that one. And as I said, it sounds like you're an athlete rather than a therapist. So send us a message and we can get one of the therapists on the mentorship that's near you to assess you and see which directions maybe you need a little bit of help with. For a posterior ankle impingement, I'm definitely looking at the deltoid ligaments there. So again, when we plantar flex, the deltoid ligament, the anterior deltoid ligament needs to be able to lengthen any tissues around tibia, any tissues around the front, the capsule, and then also a very, very important muscle which I've spoken about before, peroneus tertius. That's also going to need to lengthen as we go up on our toes. Okay, so you need to desensitize that as well. And as I said, take them through that step-by-step graded exposure then. Okay, so anterior deltoid ligaments and peroneus tertius are two big tissues that I'll be definitely looking at there to desensitize very, very early on the graded exposure program. A really good question again. I'll be definitely interested in helping the person to get their ribs moving, especially after the operation. I'll be very interested in restoring tolerance to load through the abdominals very, very quickly. So to keep it really simple, I'll be doing a lot of work teaching a person how to prolong their exhalation, to slow down their inhalation, and really getting that rib cage moving. There's various ways of that, and I'm going to do a blog on that very, very soon for you all. But yeah, just keep it very, very simple with these people. And again, that exhalation is going to get the rib cage moving a little bit, slowing the inhalation down. Then will also lengthen all the intercostals and stuff like that. That's probably going to have a bit of protective tone just from the surgery in general. Then, as I said, it's just a case of getting them moving through that graded exposure ladder then on the back of that. Okay, so for this one, it completely comes down to the assessment, what I find on the bed with this patient. Osteitis pubis, we might be tolerating load well through the lateral hip. We mightn't be tolerating load through the abdominals. We mightn't be able to tolerate through various tissues. So that, again, it just highlights the importance of that initial assessment. The big thing with these guys when you're rehabbing them is you have to get the deceleration right at the highest levels of load and speed of move. Also, the other big thing for me is where they're weak with their squeeze. Are they weak with their squeeze with the leg straight? Are they weak with their reductor squeeze at 45 degrees? Or are they weak with their squeeze at 90 degrees? That's another one that's going to give me a lot of indications of what I'm going to treat and what directions I'm going to take. And again, this is probably another good one to do a blog post on in the coming months. So again, it all comes down to the assessment, but one big tip with the rehab is do not neglect deceleration. Very, very important. Random one is right. My least favorite workout is long, slow running. I'm not built for that. Not very, very good at it. Short, sharp, very, very fast over 5 meters. That's my kind of sport and workout.